Good morning and welcome to Duke University. I'm Mike Schoenfeld, Vice President for Public Affairs and Government Relations and Chief Communications Officer, and the moderator of today's program. The COVID numbers have become almost numbing. Yesterday alone, 162,000 new cases were reported in the United States. A total of 11.36 million people have been infected since the start of the pandemic, and the death toll will cross 250,000 in the next day or two. Our economy has been disrupted, our healthcare system stressed as never before, and everyone's life has been upended, which is why the very encouraging news about vaccines has been embraced with such excitement. America's colleges and universities have been at the center of the action as both potential epicenters of the virus and the source of the research, the patient care, and education that will help bring this pandemic to a close. The numbers are concerning. According to the New York Times tracker, more than 252,000 COVID-19 cases and 80 deaths have been reported at colleges, and that number is considered an underestimate. Indeed, many individual campuses across the country have reported thousands of cases among students since the start of the pandemic. It has been said that if you've seen one college, you've seen one college. Well, one could also say that if you've seen one college COVID mitigation strategy, you've seen one college COVID mitigation strategy. Over the past 8 months, phrases like surveillance testing, hybrid model, de-densification, quarantine, asymptomatic positivity rates, and dashboards have gone from obscure lingo to familiar shorthand. Since we have a very diverse higher education system of several thousand colleges and universities, public, private, large, small, residential, commuter, etc., we have an equally diverse range of COVID mitigation strategies. In this very discombobulating environment, students, parents, faculty, and staff have been understandably confused and anxious. Communities that engage with and host colleges have been deeply concerned about safety and spread, and normal campus behavior suddenly became a matter of life and death. Today, we're going to talk about Duke University's strategy, how it came together, how it worked, and in particular, how Duke used science, math, data, behavior, school spirit, and a diverse and multidisciplinary team approach that ultimately included hundreds of people across the campus to create a safe environment that has allowed more than 6,000 undergraduate students, 9,000 graduate and professional students, and a large workforce of faculty and staff to have a healthy, successful semester that started at the beginning of August and wraps up this week. The reason we're here is to unpack a case study that was published yesterday by the CDC's Morbidity and Mortality Weekly Report, and which documents Duke's comprehensive surveillance testing program, which has been the foundation of the university's COVID mitigation plan. We will hear first from several of the architects of that plan and the authors of the case study, and then we will have time for questions. If you want to start now, you can put your questions in the Q&A box, not the chat box, the Q&A box. And a reminder that this program is being recorded and will be available on the Duke University YouTube channel if you want to watch it later or share it with others. Now let me introduce the authors and the speakers. Their full bios are available on the Duke website and in the advisories and the stories that have been circulated in advance of this program. Tony Moody, an associate professor in the Department of Pediatrics, the Division of Infectious Diseases, and the Department of Immunology at the Duke University School of Medicine, and laboratory director at the Duke Human Vaccine Institute. Tom Denny is the chief operating officer of the Duke Human Vaccine Institute and a professor of medicine in the Department of Medicine at the Duke School of Medicine. Steve Haas is an associate professor of biology and associate professor of medicine at Duke University. Mattia Bonsignori is an associate professor of medicine in the Duke Human Vaccine Institute at the Duke University School of Medicine. And Kyle Kavanaugh is vice president for administration at Duke University and the university's emergency management coordinator, who has been the orchestrator of much of this, of the activity that you are going to hear about today. Let me turn it over now to Kyle Kavanaugh.
Thank you, Mike, and good morning, everyone. It's an honor and a pleasure to have the opportunity to spend some time with you and to provide some insight into our experience over the last couple of months. As Mike had mentioned, we have been at this now for nearly 10 months, and what has evolved over the last semester has provided us an opportunity to do some enormous learning and to also rally the entire enterprise around this effort. Kristen, if I might ask if we could show the first slide, I think the first thing I would like to do is to set some context into how we've approached the entire semester. And this will provide some foundation in terms of our surveillance testing approach. I would share with the audience that this was not a organizational structure that we had in place at the beginning of the semester, but had quite frankly evolved organically. We have an overarching coordinating body. That group has been meeting every day since the end of January. A very key piece that you're going to hear from Steve in a moment is our faculty modeling team, which has been absolutely critical to our success, and I would argue has been one of the unique aspects of how we've built a dynamic testing strategy. Let me highlight just a couple of things as we go through here. As the paper indicates, we've had a robust testing strategy, which started with gateway testing of all of our undergraduate and graduate students that allowed us to identify any positivity on the way in the door, and then to start and evolve our surveillance testing throughout the semester. You'll hear from Dr. Denny, and we'll talk a little bit about the unique aspect of our surveillance testing approach here that has incorporated data management, our lab operations, and the management of 15 sites. And we think that this was one of the keys to the success that we've had to date in making this easy for our students, our faculty, and staff to actually participate in this throughout the semester. We've had a daily symptom monitoring app that many campuses have deployed as well. But one of the unique aspects here is that if somebody does indicate that they do have symptoms, there's medical management that actually follows up with that student or faculty or staff. A couple of other things to just highlight here. On the bottom rung here, we've had very robust contact tracing thanks to the redeployment of literally dozens of individuals through student affairs, through our health system, and others. This has been a very aggressive approach to how we have followed up with those that have been in contact with a positive individual and very quickly applied the quarantine process to them. Let me end by just saying that our medical management team, we've been incredibly fortunate to have professionals in employee health, occupational health, student health, primary care, and infectious disease. This organizational structure has allowed us to then engulf our surveillance testing program and then to deploy that throughout the semester. At this point, let me ask Steve to dive into a little bit deeper about the science behind our surveillance testing program.
Great, thanks very much, Kyle. So the broad goal of the modeling group was to construct models that could predict virus behavior on campus under a number of different circumstances. And the hope was that these predictions would allow us and inform our decisions for allocating resources, for various mitigation strategies, and for thinking about managing our community in terms of density on campus. These models are constructed with input from experts and with data. And one of the challenges we had at the beginning of the semester is there was not a lot of data available because nobody had ever done this before. In this regard, we relied heavily on our expert colleagues in the School of Medicine to help us make good decisions. And over the course of the semester, we've been largely very successful at limiting the transmission of the virus on campus. This success has posed an interesting problem for our modeling team, which is that we still lack a lot of data that we need for some of our more complex models. This, of course, is a very good problem to have, and it's one that's shared by a number of our sister institutions. And the solution that's arising is that many universities are getting together to share data, best practices, and information that will inform all of our models and all of our decision-making going forward. I do want to say that while we are interested in having increased amounts of data for some of our models, we have been using data from Duke to guide our decisions on a number of things. And I'd like to give one example on the next slide, which is how we allocate our sampling resources. At the beginning of the semester, we had not yet reached full capacity for processing pool testing samples. So we wanted to make sure we were making good use of the limited samples that we had. And in this cartoon on the left, what we did is we distributed the samples that we had uniformly across our student populations, both on campus and off campus. And then each day we would look for positive signals shown as a red X. And so on the right, when we identified positive signals, we could refocus some of the samples to surround those positives and make sure that we weren't seeing any transmission sneaking out from those positive cases. Now that we're at full capacity and testing our undergraduates twice a week, we still look daily at this information and use that information to adjust our sampling strategy. And with that, I'm going to hand it off to Mattia to talk a little bit about sampling and sample processing.
Thank you. So the surveillance program includes entry testing for all incoming students, individual testing for symptomatic students, and surveillance of asymptomatic students. And in this slide, I'm going to focus on the latter. A challenge of this asymptomatic student testing was how to process a high volume of samples rapidly. So we opted for a sample pooling approach in which 5 individual samples are pooled together for testing. And this was the enabling feature to reduce the workload to more manageable levels. So the sample pooling workflow has 3 steps. First, individually barcoded samples are delivered to the laboratory, and we load the samples on an automation platform, and the barcodes are scanned to track each sample's position. The 5-to-1 pooling is done using automation for consistency, reproducibility, and high throughput. So it takes about 33 seconds to make a pool, and 120 samples are processed in a single run that can be loaded on the machine. And it takes less than 3 hours to process 1,500 samples. So after pooling, each sample is archived, again, with tracked barcodes. Tracking here was the key word. We had to be able to reconstruct where each sample went, was, and how to retrieve it. And the pools were sent to Tom Denny's laboratory for PCR. So if the result was negative, we knocked down 5 samples with 1 single PCR reaction. And if the pool was positive, we proceeded with the so-called deconvolution, which is retrieving the 5 archived samples in the positive pool and send them to the clinical laboratory for individual testing. This way, we reduce the number of testing that was sent to the clinical labs. Next slide. So pooled testing was started on August 18th, was scaled up to testing targets by September 20. And the current throughput is over 2,300 samples pooled per day, 5 days a week. And as of November 17th, we processed over 120,000 samples total. And this is what enabled the very frequent testing of the student body. And with this, I think I can pass back to Tom.
Hi, thanks, Mattia, and thanks so much for everyone for participating today and enabling us to tell our story a little bit more. So I come from the HIV field and saw many of the same challenges that we have today with COVID in the early days of HIV. And in those days, we went to pooled testing and tried to develop sensitive tests to help us deal with testing large numbers of folks and doing surveillance testing as we are today. So back in the spring, we started developing a quantitative viral load assay in my laboratory with the idea that this would be useful in both some of our clinical research, but in this case, we were able to reposition this platform and offer it as a testing platform for the surveillance testing program. After we developed this assay and validated it, then it was a matter of scaling up. The other critical component of this is we developed this platform on utilizing a series of reagents and instruments that were not being used in clinical laboratories. And if you recall in the spring, we were seeing lots of challenges with supply chain issues for the clinical tests. So we wanted to make sure that we had a platform that could support the surveillance testing needs and then did not impact clinical testing needs for those that are symptomatic. And the approach that we've developed has enabled us to do that. As Mattia mentioned, we are doing about 2,300 samples per day right now. We also, the system that we have currently built, we have capacity to go to 3,200 samples per day. And our average turnaround time right now is running sometime between 18 hours and 30 hours for start of the process until we've deconvoluted a pool and send back a medically actionable result through our clinical testing. I think I'll stop there and I'll pass this back to Kyle.
Thank you, Tom. And to just kind of bring it in for a landing in terms of, so where did we end up at the point of the writing of the paper? We had 84 positive tests. What is most, I think, important to outline are a couple of different findings there. Over 50% of those came through asymptomatic students. So said differently, had we not had the progressive surveillance testing of our asymptomatic population, we would have missed those. We had a couple of really significant wins, especially in some off-campus experiences where we identified an individual who was tested positive through asymptomatic testing, through aggressive contact tracing, actually placed 8 students into quarantine, and those 8 students subsequently tested positive. As Steve Haas has educated me, it was a great way of putting a bow and tying off a potential significant outbreak. Let me end by saying, before I kick it back to Mike, that although our surveillance testing program has worked exceedingly well, it is one of 24 different mitigation strategies that we've had in place. And again, I'd like to extend my appreciation to not only the other panelists on here, but in the entire Duke community, including our students. And one of the things I'd like to end by saying is the compliance rate of our students participating in testing, I think, far exceeded anything that any of us are expected. We were well over 95% on a daily compliance rate in terms of our students actually showing up sometimes twice a week to be tested. So with that, we're feeling very good as to where we are on November 18th and looking forward to the wrap up of this semester and preparing for the spring.
Great. Thank you very much, Kyle and Tom, Steve, Mattia, and Tony for walking through it. We have a number of questions that have come in, and those who want to ask questions, again, please use the Q&A function and we will get to them. I want to start, though, by pulling back a little bit and asking about testing in general. We have all seen the stories, we've seen the photos, we've seen the pictures of long lines and testing shortages just in general across the country. How did the test that was done in this process differ from the testing that we sort of talk about, hear about in the public? Because the fact that Duke has been able to do 160,000 plus tests is tremendous. Question always comes up: is this taking away from capacity elsewhere? And let me add to that. Conversely, are there learnings or opportunities for others in the public health space around this kind of activity? Tom, maybe.
Yeah, I guess I'll take that, Mike. Great question. So a couple aspects of the test that we developed. One is it uses reagents that are not traditionally used in clinical laboratories. So when a clinical laboratory wants to do a molecular test or a PCR test, they want a testing platform that is quick and rapid. And that's generally referred to as a single-step PCR approach. We used a little bit older approach, which is it takes about an 8 or 10 hour process to get from start to finish, and it's called a two-step PCR process. These are generally reagents that are used in research laboratories and not necessarily put into a clinical platform. And then what we did do is we validated that assay by running a lot of replicates and running it in all sorts of dilution, titrations. And we were able to show that we had a highly reproducible, sensitive assay that detected down to, at the lowest level, 15 copies of virus at a very high reproducibility. I'd have to go back to the table, but I think at 15, we're about 80%, somewhere 75 or 80%. At 62 copies, we're at 100%. So the assay it's a slower PCR assay. It does not compromise the reagents that are used in clinical testing platforms. We were able to secure a supply chain to get us through the semester. And I think it has served us well for the surveillance testing application.
Great, thank you. A question for Steve from the modeling standpoint. Is there a critical mass of individuals that one needs to do effective modeling? Is there either a minimum or a maximum that you need to do to make these models strong?
Yeah, I don't know that there's a critical mass, Mike. What you'll always hear from mathematicians is the more data that you have, the stronger the models are and the better the predictions are. And so what we're really looking at here is a continuum, that as we collect data going forward, as we share data with other universities, the more data we have, the better the predictions that we make from modeling will be.
Great, thank you. We have a question from Ryan Lindsay, and this is probably for Tom. Question is there a level of incidence or percent positivity where pooling would not be recommended as a testing strategy? Ryan is at an institution that's considering a strategy, but they have a much higher case rate than Duke and the surrounding community.
Yes, there is. And I can tell you on another collaboration here at Duke with Mike Datto in our pathology department, there's a paper in press at JAMA right now that will offer a tool to universities or folks that want to look model pooling based on what their local prevalence is. So, and I'll defer to Steve and Tony for any other relevant information from our group. But basically, you're absolutely correct. If your rate of infection is too high, then you're deconvoluting more pools than you're able to escape through. So in our case, our rates are low and pooling strategies work very well. And in fact, we stated a pool of 1 to 5 because we were conscious about sensitivity and wanted to make sure we didn't miss anyone. But we have data that we developed in the laboratory that said we could go up to a pool of 20 and probably pick up a copy number down around 50 copies. So we would still be highly sensitive with our assay.
Good. Anybody else want to add to that?
Yeah, I think that.
Well, go ahead, Steve. Sorry.
I could add one thing that the arithmetic you want to do here is that if you are pooling at a level where and you have an incidence rate that's high enough that a majority of your pools are turning positive, that means you're doing more tests on deconvolution than you might if you were just directly testing students. So that's the kind of consideration that you want to make in terms of the incidence rate and the number of samples that are being pooled.
Yeah, and I'll add to that, Steve and Tom. There are a couple of other considerations there. One is going back to something Mike had said earlier about diverting clinical tests from the hospital population. If you get to the point where you've got very high incidence and you're tying things up, then it may very well not be useful to continue pooling. As Steve said, the numbers start to work against you as your incidence rate starts to rise, and that's part of our advantage here is that we've been lucky enough to have a relatively low infection rate, and so our pooling strategy has really worked in our advantage. We're using fewer clinical tests by doing this rather than sending a lot of samples to the clinical lab, which I think has been an advantage.
Great, thank you. Question from Ronald Solbrig for Mattia. Ronald asks about the dilution of samples in pooled testing. He asks if we have seen any evidence that this method is missing cases because the dilution takes the concentration below the lower cutoff limit. That is, person A has 10,000 copies per milliliter if tested alone. Diluted 1 to 5 makes it 2,000 copies per milliliter. If the detection limit is 3,000 copies per milliliter, the entire batch of 5 would be deemed negative. I have pretty much extended my far beyond my knowledge, so I hope I had the emphasis on the right syllables there. But maybe Mattia or Tony, if you could answer that.
Yes. So basically, as Tom alluded early, the test that we are using for the first screening is highly sensitive. So we did check upfront how much diluted the sample was, which were the volumes that were working for each individual sample. So the trick here was to avoid setting arbitrary thresholds on positivity. So it's very tempting when you see very low copy number, and sometimes as part of every assay, it's a false positive. And in our environment, in which we have an overall low incidence and a very high number of samples that are tested, you are expected to find false positive in this kind of setting. You're very tempted to say, okay, can we draw a line at some point to cut further down? And I think both Tony and Tom can speak on this a little bit more. We did find that was not probably the best approach, and we rather sending some more samples to the clinical lab. It's already a huge reduction. We make a huge funnel on it, and basically not excluding any sample.
Great. Anybody want to add to that?
Yeah, Mike, I can add on to that because I'm keeping the running list of all of the positive pools. I'm the one sort of managing that part of the data. And it is certainly true that if you have a very high positive pool, that you're highly likely to get a positive result when you do deconvolution. As the copy number goes down, that likelihood starts to drop off, and the math works out that way. But I will say we have had pools as low as 1 copy per mil that gave us a confirmed result. And so I don't think that we're seeing a problem with any kind of sensitivity in Tom's lab. If anything, he's picking up things that may not have been picked up otherwise, and that's allowing us to do what Steve was talking about and pivot so that we can cut off infection clusters before they really get established.
Great, thank you. Question for Kyle from Paul Brown at Notre Dame. Paul writes, at Notre Dame, we experienced outstanding cooperation among students providing tracing information, less so though later after the sanctions were applied against the hosts of super spreader parties. Did Duke experience anything similar?
We're incredibly fortunate, as I mentioned during my comments, that our student body has been nothing short of phenomenal. We certainly had our share of small brush fires, but that's what they were, small brush fires. And we had a very, very busy student affairs disciplinary semester, much more than we normally do. And I think the aggressiveness there has paid off. But no, I think to answer your question directly, that as you're probably very familiar with, contact tracing is only as good as the data you're able to unearth. And to the credit of the individuals that were involved in that, they were able to identify very objective, accurate information throughout the semester. And that has certainly been a key to keeping our number of positives as low as we have had.
Great, thank you. Question from Lena Tillett at WRAL, and I think this is for Kyle, but also for Tom from the operational standpoint. Duke University's population is much lower than state schools such as UNC, NC State, or Ohio State or Penn State. How do you see other universities having the capacity to test at scale on their campuses? And did your frequent testing come at a significant cost?
I guess I'll start. There were a couple of questions in there, Mike, and then I'll ask Tom to kind of weigh in on the testing scale piece. First of all, one of the things that we did not mention, it's mentioned in the paper, but we didn't talk about it here, is some of the language of de-densifying. And so that was an absolute key strategy, that each undergraduate student on the campus actually resided in a single room. There were shared bathrooms, but a single room, and we're confident that that played a significant role. How that plays when you start multiplying by tens of thousands becomes clearly much more complicated in an environment that's much larger than ours. But I think the de-densifying effort has to be something that we all take very seriously. I think the other learnings that we had, I think, are just a mathematical scaling issue, the issues of masking, the issue of hand hygiene, these core behaviors that we believe actually played a critical role into keeping this safe. The honest answer is we're still calculating in terms of the numerical impact. That org chart that I showed you, behind every one of those boxes, there are literally dozens of FTEs. So we have redeployed dozens of people to help with contact tracing, to help with the surveillance testing sites. Those numbers are clearly in the several $1 million in terms of our overall effort here. And Tom, let me turn it to you in terms of the scaling question about testing.
Sure, thanks, Cal. So the first thing to recognize for surveillance testing is that you do not have to have a 𝐓𝐡 𝐏𝐚𝐬 EUA approved test to do surveillance testing. And there's CDC and Center for Medicaid Services guidance that was put out early this summer that you can look to for that. And now, having said that, scaling is a challenge. But for any of the universities that you mentioned here, they have large infrastructures of research laboratories, engineering schools, and what this takes is innovation. This takes talented faculty and experience on a campus to come together and look to how they can innovate opportunities to provide this service in their unique environment. And no one size fits all. We happen to have some infrastructure and technology that was a good fit for us. It was not the perfect fit, but it was a good fit, and it enabled us to do that. And I would just say to other universities, look within, look at your, all of these universities and the large universities are doing molecular biology. They have PCR applications. It's a matter of taking an assay and applying that and applying it in a good reproducible fashion for you don't want to have a sloppy assay, but you do not have to have an FDA approved CLIA or CAP laboratory to do surveillance testing. And there are a number of platforms out there today, such as NGS sequencing and other things that lend opportunities here. So I think the challenge is to just be an innovator in your unique setting and see what tools you have in your toolbox and then work to redeploy them to meet this need.
Great. Let me also just add, if I could use the moderator's prerogative, Kyle talked about the many different aspects. I think if you actually rack up what all of the things that's been happening at Duke over the last 6 months or so, you will find, to use that cliche, not a series of switches, but actually a whole lot of dials that have been turned. Dials regarding densification of living, dials regarding classes, dials regarding employment, dials regarding the use of facilities, and dials regarding the amount of activity on the campus. There are many different aspects of this. Certainly testing and the surveillance testing is the bedrock and the foundation. None of this would have worked without it. I think we think it's pretty clear, but all of the other things came into play as well. And two other things, Kyle mentioned the engagement of students. I would say, I mentioned school spirit at the top. We did very much from the beginning work on focusing the culture of the institution around Duke being united and what people wanting to be here and wanting to do what they had to do. The second thing, and we absolutely have to credit this, as we all do, is some measure of good luck. We have been very lucky as this has gone on. And the individuals here and the many others around them have helped create that luck, but we also have been very lucky. We do have a few more questions here. This one is for Steve Haas. In the Duke Daily newsletter, you remarked that we now know more about transmission of the virus than we did in August. Can you expand on what we've learned between August and now about transmission?
Sure, Mike. Yeah, I think what we've learned over the semester, and there was great concern that we were going to see transmission on campus in classroom settings, for example, or other settings. And our experience so far is that transmissions are not occurring. We don't have any evidence that transmissions is occurring in a classroom setting. And I think this fits with the discussions we've had with our sister institutions that the kind of classroom learning that we're doing here, the experience that we're providing is not contributing to on-campus spread.
Great, thank you.
Mike, if I may, just one small addition to that. I think we're all very aware of some of the highly publicized kind of large gatherings that have resulted. Although we haven't had it, I think one word of caution is, I think Steve has educated me this as well, we haven't had the cluster, but we've had the chain. And what does that mean is that some of our positivity experience have been from rather small gatherings, 2 to 4 people, a lot around food, letting masks down, and then those 2 become 4 and those 4 become 6. And so that's one of the things that we're continuing to wrestle to the ground.
Great, thank you. Question from 𝐓𝐡𝐞 𝐏𝐚𝐧𝐞𝐥𝐢𝐬𝐭𝐬 at WUNC. Probably for everybody. What was the most important part of your strategy in keeping cases down through the semester? Kyle, maybe do you want to start with that, and we'll go down the line?
Well, I think first of all, I think just the overall engagement of our community. It would be hard, Mike, for me to identify a portion of Duke that actually hasn't played a role. And so I would honestly label it was the totality of this community engaging in every aspect you can think about. The folks that are on this panel are simply indispensable to where we have gotten ourselves to. But so are the dozens of people, if not hundreds of people, in student affairs, in facilities, our bus drivers, our custodians, and our students. So my answer would be it's the totality of the engagement of the community.
Great. Tony, could I ask you to weigh in on that?
Sure, Mike. And I agree completely with what Kyle said. I think that what has really struck me going through this entire process is that everyone has stepped up and that we've had really strong leadership at every position in that chart of boxes that Kyle showed at the beginning and end of the presentation. I mean, there's not been a single person who has ever come up and said, that's not my job, or that's not something that I'm willing to step up and do. Everyone has stepped up. The other thing that I think we made some very conscious decisions about early on that were really important is we specifically tried to not overcomplicate things where they could be simple. We made a bunch of decisions early on about the testing strategy, about distribution of materials, about how people were going to link into the system. And we specifically tried to make everything as easy as it could be, both for those of us working on the specimen side, but also for the students. By having distributed testing centers and not funneling everybody into a central location, we cut down on lines where transmissions could occur. We made it very simple for students to engage and, not have to walk up and say, well, there's an hour-long line, I'm not going to be able to do it today. We made it as easy as we could. And that, I think, has really paid dividends for our testing program.
Great. Steve, let me ask you a variation of that question. You are a professor of biology. You teach undergraduate and graduate students. How have you seen, as you have interacted with your students, how have you seen the impact of this approach directly?
So I think that keeping transmission low on campus provides an environment where students can focus on their research, on their studies, without the kinds of distractions that one has if there was a consistent worry about transmission or a concern about going to class. And as well, the experience we have on campus with face-to-face teaching can't really be matched by remote learning. And so I think having students here is a real benefit, and the ability to keep transmission levels low on campus has created a learning environment that I think is far superior to anything that you might see in remote learning, where you have all the distractions of being at home.
So we have a few more questions in the time remaining here. This is from YouTube viewer Joe Spears, and I'd like maybe Mattia and Tom to weigh in on this. How can the Duke model be used in non-university settings? For example, how can a county public health department use elements of this model to reduce or to identify or reduce COVID cases?
Yeah, maybe I can start on this. And one key aspect of our process was that we didn't limit to a single population, just some students. We offer also to faculty and staff. We didn't limit to just testing. There was a strong encouragement and emphasis on social distancing, on masking, on hand washing, and the university did a lot of other implemented a lot of other measures like packaged food or operational differences that really all worked trying to curb the problem from different angles and corners. So I think sort of mimicking what Tom was saying before, this kind of model can be adapted just by looking at the specifics of an environment. It probably can't be taken and dropped into a different part, but basically looking at all the different variables and attacking them all at the same time really avoided that something was slept through this part of the year.
Great. Tom, did you want to add?
Yeah, I would just, so from a public health perspective, I would just say leadership in behavior, leadership in convincing people to mask, to social distance, to frequent hand washing, all the things that we know help to reduce transmission. And then as far as testing, I think we're getting to a point where there may be some newer technologies coming forward that may aid in point of care testing or local testing resources. They're not there yet for the kind of test volume that we're doing. But I think the biggest, I like testing is important, but it's a marker of behavior. And in our example, Duke, we had a unified message of behavior, and the community followed it. The testing helped us pick up where we were having some problems, that we were then able to be aggressive and say, okay, we have to contain this, we have to stop this before it gets bigger. And I think that's for me, that's the message that people need to understand.
Great. Mattia, you had something you wanted to add to that?
Well, it has been covered, and
Okay.
yeah.
Great. So I want to thank everybody. I want to thank you on several levels. First, I want to thank you for your participation today on in this very informative conversation. More importantly, as a colleague and as a fellow citizen of Duke, I want to thank you for your leadership and for the direction and for the activity and intellectual direction that you all have provided to this effort. And I know I say that on behalf of our thousands of students, their parents, our faculty, our staff, the community that really has brought Duke to, that really created this environment that allowed Duke to be successful. So let me again say thank you to Tony Moody, to Tom Denny, to Steve Haas, to Mattia Bonsignori, and to 𝐲 𝐏𝐚𝐬𝑧𝐞𝐥𝐢𝐬𝐭𝐬 for their work and for their efforts today. If you would like more information about this, please do check out the various Duke University websites. You can go to today.duke.edu. You can sign up for the Duke Daily, our daily newsletter. You can follow us on social channels at DukeU on Twitter, at Duke University on Instagram, and our Duke University Facebook page. And we hope that you will come back early, that you will come back often, and that you will continue to follow the activities that are taking place here. So again, on behalf of everybody at Duke University, thank you all for being here today. Thank you for your interest, and we hope to see you soon.